Welcome back to the next session. The first question we are going to discuss here is enterocutaneous fistula. Enterocutaneous fistula. What do you mean by the word entero? Entero means it has to be an intestine. Cutaneous means it has to be skin. So what is this enterocutaneous fistula? It is an abnormal connection. Abnormal connection between what? Entero means what? Small intestine. Usually the small intestine, and cutaneous means what? Skin. So the abnormal connection between the small intestine and the skin has to be our enterocutaneous fistula. Coming to the causes of enterocutaneous fistula. First cause is post-surgery. This is very important cause, and it is the most common cause of a enterocutaneous fistula. This is the most common cause of enterocutaneous fistula. So iatrogenic, or you can call post-surgery. Why after surgery it is occurring? Maybe due to anastomotic leak, maybe due to inadvertent enterotomy, or various other reasons. Post-surgery is the most common cause for this enterocutaneous fistula. Now, what might be the other causes? Write it down. Crohn's disease, radiotherapy. After giving radiotherapy also there can be formation of a fistula, and abdominal trauma to the abdomen, abdominal trauma. These are the other causes, but single most important cause is post-surgery. Now, what is the clinical features with which the patient is going to present to us? Febrile patient, febrile post-op patient, post-operative patient with a erythematous wound. Okay, this is the complaint. Now, if you are going to open the sutures, what you can see? There will be leakage of enteric contents. Okay, when you open those sutures through this fistula, the contents of the enteric contents are going to come out. I am going to divide fistula into low output fistula and a high output fistula. Sir, what is low output and what is high output? If the amount of effluent means which is coming outside the fistula, if it is more than 500 ml per day, it is a high output. If it is less than 500, it has to be low output. So more than 500 ml of effluent per day has to be considered as high output. If it is less than that, it is considered as a low output fistula. Now, due to these contents are coming outside, enteric contents and all those, there can be excoriation of the skin excoriation. Ultimately, this may lead to secondary infection of the skin also can happen. Okay, not only that, the fluid is going to come outside through the fistula, so enteric contents are also coming outside, so there will be electrolyte imbalance. Electrolyte imbalance will be there. Let us look at the fistula. Suppose this is the GI tract. Let us assume this might be the fistula tract, and this is your outside skin. Okay, this is your outside skin, and this is your gastrointestinal tract. This is your fistula. Now, when I have drawn two fistulas for your understanding. Let us assume the fistula is distal. Suppose the fistula is here. So if the fistula is there here in the distal part, the enteric content or the content which is there in the bowel can be absorbed here, 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 here. Everywhere it can be absorbed, but here it is going to pass out. It is not going down, but here it is passing through the fistula and coming out. Whereas coming to the fistula which is proximal, it can be absorbed only up to this level. The content which is there in the bowel can be absorbed only till this level. Beyond which, what is going to happen? It is going to pass through the fistula. So with this basic knowledge, can you tell me which fistula is dangerous? I mean, which fistula causes more damage? Is it a proximal one or is it a distal one? Yes, proximal one is the one which is causing more damage. Write it down. More proximal the fistula is, more electrolyte imbalance it is causing. Okay. Do I understand the concept behind that? Okay. Now, most of the fistulas, they can heal themselves spontaneously. So, heals spontaneously within 6 weeks. Within 6 weeks, most of the fistulas are going to heal spontaneously. If at all, if they are not healing spontaneously, then what to do? Then surgery is going to be indicated in those cases if they are not going to get healed. Can you tell me few factors which may impair the healing of the fistula? If at all there is distal obstruction, okay, or if there is epithelial continuity between the skin and bowel. So if the skin and the bowel, if there is epithelial continuity is there, then it is going to impair the healing of the fistula. And if at all there is abscess formation, the healing is going to be impaired. Okay. In how to know all these things, which investigation I have to do? I have to perform CT scan. Okay, CT scan may tell me whether there is any distal obstruction or whether it is any abscess, all these things. So I have to get a CT scan. Coming to management of a case of fistula. If it heals spontaneously, yeah, that's fine. But if at all there is a case of fistula, how we are going to manage? What are all the principles of management we will look into? So the principles of management can be easily understood by SNAP. Let us try to elaborate it. Yes. Yes means what? S means elimination of the sepsis, and also S means skin protection. Okay. Elimination of sepsis, and at the same time S also means skin protection. Okay. One thing I want to emphasize here is, if at all there is already skin infection, okay, around the fistula is coming out through the opening in the skin. If at all there is a infection of the skin, you cannot perform surgery in that case. First you have to treat the infection and then only you have to perform the surgery. Okay. That is why the first step is always elimination of the sepsis, and you have to do skin protection. Coming to N means what? Nutrition. So which nutrition? Fluids you have to give. Okay, as electrolytes are also lost, electrolytes you have to give. Even carbohydrates, vitamins and all those things, proteins, all those things also. You can write fluids, you can write electrolytes also. Okay, obviously you are going to give vitamins and carbohydrate diet, all those things. Now coming to A. A means anatomical assessment. You have to assess the fistula, the exact location and the type of fistula. You have to exactly know the anatomy. How to know that? The position of the fistula and all those things. You have to do radiological investigations. You have to perform some contrast studies to know all those things. Now coming to P. What is P? P is planned surgery. Definitive planned surgery. So when you look at the management, it has to be in a sequential manner. First thing is elimination of sepsis and skin protection. Next you have to maintain fluids and electrolytes, nutrition. Then you have to assess anatomically using contrast studies. And then if required, you have to perform surgery. Definitive surgery is planned in a later date. Okay. This is the principles of management. Now I am telling you surgery. Sir, what is the surgery? What surgery we are going to do here? Let us this is your bowel, small bowel. This is the fistula, and this is your skin. Okay, this is your skin. Now first thing I have to do is I have to remove the entire fistula. I have to remove. Okay, entire fistula I have to excision. Now not only that, the segment of the bowel which is involved in the fistula formation should also be resected. After resection of this, I have to anastomose this part with this part. Okay, write it down. First thing is I have to do fistula excision. After that, I have to remove the involved bowel segment. Involved bowel segment I have to resect. After that, I have to do reanastomosis. Okay, this is how we have to do surgery for enterocutaneous fistula. Okay, now moving to the next topic. Next topic we are dealing here is papillary cancer of the thyroid. I have already written all the major points over here. Just we will go through and try to understand what is papillary thyroid cancer. You already know thyroid cancer is of many types. Papillary thyroid cancer, follicular thyroid cancer, medullary thyroid cancer, maybe some other types, anaplastic is there, or Hertel cell variant is there, all those things. Out of all these varieties, the most important and the most common variety is papillary thyroid cancer. It is the most common type of a thyroid cancer. Coming to age of presentation of a thyroid cancer, it is going to present at the age of 30 to 50 years. So the clinical presentation is of a 30 to 50 year old female. So I have already written the females 30 to 50 years is the age group. Next, various risk factors which are associated with the papillary thyroid cancer. First and foremost important risk factor is ionizing radiation. Very important risk factor, ionizing radiation. Any individual who has a prior exposure to ionizing radiation is always at risk of developing papillary thyroid cancer. Let us tell you one natural incident. Chernobyl. You already know that Chernobyl, radiation exposure is there. Especially when the radiation exposure is there at a young age group. I mean young children age group, when exposed to such a radiation, in the future what happens is they always have a risk of developing this papillary thyroid cancer in them. Okay. Next, family history of thyroid cancer is also a risk factor for papillary thyroid cancer. There is a syndrome, not very common, but you should know, Gardner syndrome is associated with papillary thyroid cancer. And one more thing, even some cases of thyroglossal cyst can also get complicated into papillary thyroid cancer. Okay. After risk factors, let us move into the clinical presentation. Coming to the clinical presentation, it is going to present as just a asymptomatic palpable thyroid nodule. So it is presenting as a nodule in the thyroid which you can palpate, and there won't be any other symptoms, okay, like pain or and all those things. It won't be there. Just a asymptomatic palpable thyroid nodule is the presentation of a papillary thyroid cancer. And sometimes what happens is, the most common route of spread in case of papillary thyroid cancer is lymphatic. Very, very important point this. Most common route of spread in papillary thyroid cancer is lymphatic, whereas in follicular thyroid cancer it is hematogenous. Papillary thyroid cancer it is lymphatics, follicular thyroid cancer it is hematogenous. So as the lymphatics is the one which is the most common route of spread, it can even spread to the cervical lymph nodes. There can be involvement of the cervical lymph nodes. Sometimes what happens is, there will be, this tumor is going to metastasize to the lymph nodes, and due to this distant metastasis, what happens is, you can see even before the main thyroid, instead of main thyroid swelling also, you can see a swelling somewhere else. So that is called as lateral aberrant thyroid, which is presenting due to distant metastasis from the thyroid malignancy. Okay, lateral aberrant thyroid presentation is seen in papillary thyroid cancer. Next, coming to this microscopy, I think you all have studied in pathology also. You can see, I mean, if you carefully, okay, if you carefully observe, you can see all these papillary projections. You can see, okay, can you see all these papillary projections? These papillary projections, yes. So papillary projections you can see on the microscopy. Not only that, can you guess what is this? What is this red color structure? This is summoma body. Summoma, thyroid cancer with summoma body is always a papillary thyroid cancer. Okay. Coming to the nucleus, there is a characteristic saying called as orphan Annie eye nucleus. Okay, it is called as orphan Annie eye nucleus, or ground glass opacification you can call. Orphan Annie eye nucleus is a feature of papillary thyroid cancer. Not only that, you can see intranuclear grooving also you can see. Now coming to, you have done FNAC. FNAC is going to show you malignancy. It may show you a papillary thyroid cancer, or it may show you a follicular thyroid cancer. Why I am discussing both these things here is, the management for both of them is same. Okay, I have already told you the features on microscopy: orphan Annie eye nucleus, intranuclear grooving, papillary projections, and the summoma bodies. These are the 4 entities already given there, which are for papillary thyroid cancer. Now, how to treat this case? How to treat means, first I have to do certain investigations to stage this. So what are all the investigations? On one side, I have to get an indirect laryngoscopy. I have to get a CT scan. Okay. So how to assess whether there are any distant metastasis? One option I have is thyroid scan using a gamma camera, thyroid scan, or I can even get a PET scan also. Okay, and I have to get serum thyroglobulin levels also. Okay, now these are all the various investigations which are used for staging. After staging, what I have to do is I have to treat this case. Okay, if you ask me how to treat a case of papillary thyroid cancer, the main treatment modality is always surgery. Okay, there are other things like radioactive iodine ablation, that what it is a additional treatment that we will come to. So first and most important one and the main treatment is surgery. So which surgery to do, we'll look. If at all it is less than, if at all the size of the tumor is less than 1 centimeter and there is no lymphovascular involvement is there, no lymphovascular involvement and the size is less than 1 centimeter, I can do active surveillance in this case. I can do active surveillance in this case. I need not opt for surgery. Now, if at all the size is between 1 centimeter to 4 centimeter without any lymph nodes involved, without any extra thyroid tissue involvement, and the age is less than 55 years and there is no history of radiation or radiotherapy. If all these things are there, I have to do hemithyroidectomy. In hemithyroidectomy, some part, okay, it is not total, it is a hemithyroidectomy, not complete thyroid is removed, some part is going to be left. Whereas if any of these things are going to be positive, okay, any of the things which are mentioned are going to be positive, I have to do total thyroidectomy. Okay, if at all I have done total thyroidectomy, I have to replace with the thyroxine. I have to keep on a medical treatment with the thyroxine. Why? Because there is no thyroid means there won't be any thyroid hormones. Okay. Absence of thyroid hormones will lead to increase in the TSH. That is why TSH suppressive therapy we are going to call it as. So we have to give thyroxine to this patient. Now, coming to, I have told you main entity is always surgery, and after that in addition you can give RIA. Who is RIA? Who is RIA? RIA is not Dominus daughter. RIA means radioactive iodine ablation. Okay, radioactive iodine ablation is called as RIA. Now, what are all the indications I have already mentioned there? If at all lymph node involvement is there, or if it is involving in the both the lobes, that is maybe multicentric tumor it is, or if at all there is distant metastasis or extra thyroid involvement is also there. Okay, and if it is a familial type of thyroid cancer, or the serum thyroglobulin levels being more than 5 nanogram per milliliter, these are all the indications for giving radioactive iodine ablation. Lymph node involvement is there, distant metastasis is there, serum thyroglobulin more than 5 nanogram, family history is there. Okay, these are all the indications for radioactive iodine ablation. Now, if at all the lymph nodes are involved, what I have to do? The moment there is involvement of lymph nodes, check whether it is central lymph nodes or lateral lymph nodes. If it is the central lymph nodes which are involved, I have to do central neck dissection. If the lateral lymph nodes are involved, I have to do ipsilateral modified radical neck dissection. Along with that, I have to do central neck dissection also. Central lymph nodes being involved, central neck dissection. Lateral lymph nodes involved, ipsilateral modified radical neck dissection plus central neck dissection also. Okay, this is how to do in if the lymph node involvement is there. Now, follow up advice. How to follow up this case means whether there is any recurrence is there or any tumor which is left apart. Okay, for all these things, what to do? You have to get serum thyroglobulin levels. Okay, once in every 6 months. six monthly you have to do serum thyroglobulin levels. Not only that, you can follow up with the ultrasound, and you can follow up with the thyroid scan also once in every 6 to 12 months. Okay, 6 to 12 monthly you have to get ultrasound and a thyroid scan. This is in total about papillary thyroid cancer. Okay, in about other cancers also we will deal in other sessions, but in papillary thyroid cancer, for a short note, this is enough for you. Okay. Just a second. Now coming to the our next topic. Our next topic is about fibroadenoma. Fibroadenoma of the breast. So there are many benign conditions of the breast, under which one important one we are discussing here, that is fibroadenoma. Right. This is the most common cause of benign breast lump. Okay, in a female between the age of 15 to 25 years. So the age group also I am telling you here itself. Benign breast lump in a female aged between 15 to 25 years is your fibroadenoma. Now, fibroadenoma, why it is occurring? Because it is occurring because of the hyperplasia of the lobules. So because of hyperplasia of the lobules, this fibroadenoma occurs. Hyperplasia of the lobules. Now, fibroadenoma, suppose I am very poor at drawing. Okay, fibroadenoma, what is the, this is just a breast only. Fibroadenoma, what is the usual size of a fibroadenoma? It is usually, the size is usually 2 to 3 centimeters only. Okay, a 2 to 3 centimeter mass in the breast in the age group 15 to 25, which is benign in nature, is your fibroadenoma. And one more thing is, it is highly mobile. Okay, as it is highly mobile, I can call fibroadenoma as breast mouse. Okay, just a second. Okay, breast mouse, I can call fibroadenoma as breast mouse due to its highly mobile nature. It is capsulated. So this fibroadenoma is going to have a capsule around it. So it is a capsulated tumor. Not only that, and it is a well-defined one. Okay, well-defined benign lesion which is capsulated. Now, suppose a female came to me with a with a lump in the breast. I have done a ultrasound. First, anyhow, I am going to do clinical examination. After that, I have done an ultrasound. Suppose on ultrasound, it shows me that it is a case of fibroadenoma. So, suppose a patient, a female, that to the age between 15 to 25, came to me with a lump in the breast. I have examined and then I have sent her for ultrasound. On ultrasound, it shows fibroadenoma. Now she came back to me with reports and she asked me, what should I do now? What I have to say to her? Should I remove the fibroadenoma? Should I perform the surgery on her? Or should I give any treatment, any medical or surgical or anything? The treatment of choice for fibroadenoma is always observation. You have to observe the patient. Okay, the best thing you have to do in fibroadenoma is you have to observe. Now the question arises, should I get a biopsy done? Okay, should I? Why? Because there is always a lesion. It can be cancerous also. So should I do a biopsy in this case? Should I do biopsy in this case? Means biopsy is not routinely indicated. When we should look at biopsy means, think of biopsy means, I have told you the age of presentation is between 15 to 25 years usually. If the age is more than 25, I will send her for a biopsy also. Even though it is looking like a fibroadenoma, it shows fibroadenoma on ultrasound also. I'm not going to observe. To be on the safer side, I am going to get a biopsy. Okay, if the age is more than 25. Not only that, if on ultrasound, if I see any atypical features on ultrasound, then also it is always better to get a biopsy. Okay, now certain medications can treat this fibroadenoma. Anti-estrogens, okay, anti-estrogens such as tamoxifen or meloxifene. Anti-estrogen drugs, tamoxifen or meloxifene, these drugs can cause regression of the fibroadenoma. Estrogen drugs like tamoxifen and or meloxifene can cause regression of fibroadenoma. Sometimes I have told you the size of a fibroadenoma is only 2 to 3 centimeter in size. Sometimes during puberty what happens is there can be formation of a giant fibroadenoma formation can also occur. Write it down. Giant fibroadenoma. Sir, define the word giant. I told you the fibroadenoma is only 2 to 3 centimeters size. If at all the fibroadenoma is more than 5 centimeter in size, then it is a giant fibroadenoma, which usually occurs during puberty. So during puberty, sometimes we can see giant fibroadenomas. What I have to do in these cases? I have to remove them. I have to do enucleation. Obviously with a inframammary incision I am going to give. Inframammary incision after through which I am going to remove that. Enucleation has to be done. Now just I want to mention few mammographic findings here. On mammogram, there is a name calcification called popcorn calcification. Popcorn calcification on a mammogram is a feature of fibroadenoma. Okay, popcorn calcification on mammogram is a feature of fibroadenoma. Now, this is somewhat new to you. Next sentence. There are patients who may underwent renal transplantation. Okay, suppose there is a patient who underwent renal transplantation. After renal transplantation, you already know any transplantation, we are going to give immunosuppressive drugs to the patient. Suppose we have given cyclosporin A. Cyclosporin A we have given to our patient. This is going to cause a benign breast condition that is nothing but our fibroadenoma. Okay, this you should be aware of. A patient, a post-renal transplant patient who is on cyclosporin A therapy found to have a benign breast mass, diagnosis fibroadenoma. Very important. Okay, I have already told you that I have treatment of choice in fibroadenoma is always observation. When to do biopsy also I have already told you. If the age is more than 25 or if there are atypical features or seen on ultrasound, I have to do biopsy. Now, even in case of fibroadenoma, there are certain indications where I have to do surgery, okay? Where I have to do surgical excision of the fibroadenoma. What are they? Write it down. Indications for surgical excision. If at all the age is more than 30, if the age of the female is more than 30, better to do surgical excision. If at all you can see any suspicious features on imaging, if at all you see any suspicious features on imaging, better to do surgical excision. If there is atypia on histology, if you do a biopsy, on biopsy you can see atypia, then also surgery. If at all size is more than 5 centimeter, the size of the fibroadenoma is more than 5 centimeter is also an indication. And if at all there is family history of any breast cancer, then also, even if there is any family history of breast cancer also, surgery is indicated. So fibroadenoma, most common cause of benign breast lump in a female aged between 15 to 25. Okay, it is going to, the size is somewhere between 2 to 3 centimeter. It is going to have a capsule around it. Okay, by chance if I see on ultrasound the fibroadenoma, the treatment of choice is nothing but observation. The treatment of choice for fibroadenoma is observation. When to do biopsy? Age more than 25, or if there are atypical features on ultrasound. Okay, next. We have certain medications, anti-estrogens we can give, tamoxifen, ormeloxifene, these things we have. There is an entity of giant fibroadenomas is there, which occurs during puberty. What to do? Enucleation has to be done, surgery has to be done, obviously through the inframammary incision. Next, coming to the mammogram, you can see popcorn calcification. Next, what are all the indications for surgery? If the size is more than 5 centimeter, or if there is family history of any breast cancer is there, or if the age is more than 30 years, or suspicious features of malignancy, you can see, or if there is atypia on histology also. These are all the indications for surgical excision. Okay. And one more thing which I have already told you is post-renal transplant cyclosporin A, always a risk of fibroadenoma. Okay, this is in total about fibroadenoma. Thank you for watching.